Hello, everybody. I'm Edward Booty. I'm the founder and CEO of reach52. We're a Singapore headquartered social enterprise focusing on rural health access. So looking at connecting low and middle income communities to essential healthcare services. We operate across the Philippines, Cambodia, India. We've just launched in Indonesia, and we're looking to grow into Kenya as well later in the year. And we're going to tell you a bit about our model, and then also some case studies and some of the data or outcomes we've been getting from delivering last mile health services in these markets. So just to start with our name, people always ask. So yeah, we take our name from the fact that 52% of the world can't access healthcare. So we're looking to build tech and a network of agents or community health workers to use this tech that really connect people to essential products such as medicines and insurance plans and services such as screening and doctor's advice as well. Just in terms of our solution, because it will orientate, I guess, for the rest of the presentation. We basically go and train a number of agents in rural areas. We currently have around 3,000 across the three main markets that we open in, with the two coming online later in the year. So yeah, we go to these rural areas, we train one or two people in that community, often the community health worker. And then, yeah, we give them a phone, and they are using an Android application that we have built that doesn't require the internet to firstly collect data on healthcare needs. So we train these people. They then go door to door and collect, key health indicators such as current diseases, medicines, symptoms, income levels. And yeah, really just look to have this network of people that then goes round and helps, us and our partners understand community needs through door-to-door, predominantly data collection. And then based on having that data and having that network of people, we run more targeted health awareness campaigns and screening campaigns, and really look to bring medical advice to the community, always in partnership with government. So, government doctors and government nurses are fully embedded in our programs. And almost to bring it to life, we might have, say, collected data on 1,000 people with these one or two people in that village. We then know a certain kid hasn't had a vitamin, or a certain person might be at risk of diabetes, or whatever it might be. So as through the tech, they can run the events, make more precision door-to-door interventions by following a sort of work list we give them that's driving from the data, and really just look to personalize and to some extent automate some of the identification of at-risk patients and bring these relevant services to the community, and then those people in the community really activate them to get them to come to the right place at the right time. And then, yeah, that same network of agents is also ordering medicines, consumer health products, and insurance plans. So that same one or two women might be collecting data, asking you to come to a diabetes event, or your friend to giving them a vitamin for their child or whatever else. But then you can also order and distribute or receive products from them. You pay this agent for, say, a discounted medicine or an insurance plan or whatever it might be. So yeah, really looking to train these people, collect data, run the services in a more targeted way, also bring affordable private sector products into communities. And then we're making money through a small margin on those products that we distribute, generally significantly less than the cost of time or travel to the local health centre or the local pharmacy that can be many hours away. And also businesses fund the awareness and screening campaigns. So working with pharma companies or grant makers or insurance companies to fund awareness and screening events, really training the government health workers and giving them the commodities they need to improve primary healthcare. So a mixture of sort of business financing coupled with small margins on these products that we distribute. All of this is powered by a tech platform that we've built. We've sort of had to engineer it for very old, low-spec devices. So we're supporting Android versions that are about 7 or 8 years old, which is pretty old in the tech world. It works fully offline. So once the tech has, been synced for the first time, you can do a lot of your transactions offline and then sync to the internet periodically. And I guess, all the services that I mentioned above are really just here in the app. So doing the data collection, the health records, running the education and training campaigns, running the awareness events, doing door-to-door outreaching for specific households, running the local services, signing people up for screening, ordering medicines, ordering insurance, managing that last mile delivery from our sort of distribution partners in cities. All those sort of touch points are managed through this tech that we've been building for the past 3 years or so. Obviously English on the screen, but 5 languages supported for all the markets we work in. And obviously there's other touch points in the system, as I'm sure you're thinking. So, we do also have a number of web portals for the government to view their data, to upload the events, to upload, when they'll be in the village, or whatever it might be. There's a portal for pharmacies. So as we're ordering the medicines, we have partner pharmacies who are doing the dispensing and packing per patient, so they can view their orders, accept the orders, update the status. A portal for our insurance partners, really telling them, who's buying insurance, approving the plans, starting to get into claims management. So 3 or 4 web portals to support the stakeholders we need to interact with, reach these communities as well. And then, when we sort of get into the resident experience, this is just a example tarpaulin that we have up. I think it's in the Philippines, and again, obviously translated into local language. But we really just look to bring affordable services across medicine, insurance, diagnostics that you see here to villages. So instead of traveling 2 or 3 or 4 hours to a hospital or a pharmacy and paying more, for your services, we're looking to really work with private sector to get these products at a more affordable price and deliver them in the community. So it's cheaper, and you don't have the cost or time of travel, which is incredibly important for lower income people that are often paid on day wage labor, and really can't afford to take a day off to travel 3 hours to go to a pharmacy and then 3 hours back, or a hospital, or whatever it may be. And as mentioned, we're sort of very proudly a social enterprise and a socially orientated organization, but we do actively collaborate with private sector. So, we work with pharmaceutical companies and insurers, and we do a lot of health worker education. We do a lot of awareness campaigns for diabetes or maternal health issues or nutrition or hepatitis, whatever it may be. We obviously do active screening through training the health workers, pricking people's finger for diabetes or whatever it may be. We support the customers, such as insurance claims processing, like I mentioned earlier, with our insurance partners, or glucose monitoring for people that we work with on diabetes. And of course, we also look to get affordable, discounted products from these private sector organizations and support the sort of direct-to-patient distribution of any discounted medicines or other products that we might get. And I guess just over the years, just talking about bringing this to life and sort of how it worked, I'll make this all build as one. But we basically just do a lot of research. So obviously by having the field force, the first step, as mentioned, is going door to door and collecting data. We also do a lot of primary research, really looking to understand the communities, the doctors, the pharmacies, what problems do they have, designing research methodologies, to really understand the root cause of these problems, doing the data collection and qualitative, quantitative interviews, processing that data and doing analysis. And that's what we take to our business partners to say, look, here are the gaps, and and here is where you can support, and here is, a social business opportunity. You can train the health workers, but there's also a need for low-cost insulin, say, which is one of our biggest projects. It's just completely unaffordable to people in lower-income communities, often $20 a month, where incomes can be as little as, $100 a month. People just can't afford to spend 20% of their income just on a vial of insulin. So we went to insulin providers, found one in India that was willing to do it for $3 a month from 20, and then we order it and we deliver it back to the communities, managing the cold chain. Again, people don't have to travel, and their medicines are 85% lower than if they went to a pharmacy in the first place. So yeah, really deeply rooted in data and deeply rooted in really hands-on community interviews as well. And then, when we talk about the partners, we've sort of got three categories. And again, I'll make this all build straight away. Very much working with pharmaceutical companies, J&J, Gilead, Philips, on the ultrasound side. So a mixture of, medicines as well as med tech or device manufacturers, and partners such as Zuellig and DKSH on the distribution side as well. Also very focused on insurance and access to affordable insurance, working with some of the partners you see there on the screen, which are a range of local health insurers. And then, really passionate about health access models that are data-driven and innovative. So we've been part of a number of accelerators with Facebook and Google, been doing a lot with our data about sort of really precision targeting of essential health services with IQVIA and other partners, and got various grants for some of the more innovative tech that we've built to manage the delivery of these services as well. And then, just people always sort of wonder how big we are and how much we've grown. But we have about 300,000 active patients on a monthly basis at the moment. We have about 6 or 7 partners we work with on the ground to train the agents, because often we do that in partnership with NGOs and give them a revenue source to help us hire the field force so we grow faster. We've got about 6 growth partners. As mentioned earlier, again, we have about 3,000 in our field force at the moment, about 500 communities, 20 big global partners, offering about 7,500 medicines and other affordable insurance products at the moment. So not quite a tiny startup, but also a long way to go in sort of enabling health for all, but certainly starting to get some more traction, which we've seen grow even faster since COVID, given some of the health access barriers that many people face as the government resources become more limited and focused elsewhere. Team, not that it's super important, we're about 40 or 50 people now across our offices headquartered here in Singapore. And just in terms of how we work with private sector, that's always a question. And for some of the pure impact or NGO types on the call, it's often something people are uncomfortable about. But we often do what we call subscriptions. So a pharma company might pay us $10 per health worker trained or $2 per diabetic patient we screened. So more output-based pricing based on us, delivering health services, which we let to take the risk on, and they pay. But then we also do services or projects around market research or training health workers and really just supporting their strategy to create a new sort of business model for emerging markets. And we're really passionate about growth as well. I mean, we try and not be a pilot, or there's endless pilots in healthcare access and tech and pharma and all the spaces that we work in. It's an endless pilot in a way, as I've heard somebody say before. But we're looking to scale. So our goal is just how do we connect 250 million people to healthcare by 2030, which is of course when the Sustainable Development Goals and health for all should be realized. As our name suggests, 52% of the world still can't access healthcare, and unfortunately that's actually increasing on a regular basis as population growth in lower income countries is faster than in richer countries where there is health for all. The number of people needing healthcare is going up, and we're keen to build something that can really scale, working with NGOs on the ground to hire these women, and then creating this sort of digital platform and network of partners to really connect people to public and private health services in a sort of efficient, community-led way. And yeah, well, I guess normally if I was doing a presentation with you all face to face, I'd love to take some questions now and hope everybody understood it, I guess. But yeah, firstly, just do welcome any questions offline. So it's just edward@reach52.com, or you can find me on LinkedIn, Edward Booty. Yeah, so please do feel free to message me and ask for these slides or whatever if you are confused or would like to connect. Yeah. But for the rest of the 5-10 minutes or maybe 10 minutes, we just thought we'd share some case studies of how this has worked, basically. So yeah, just going to run through a few different partnerships, what we did and how it went, and so on and so forth. So starting with Johnson & Johnson, who's currently our biggest partner, the challenge that we sort of set ourselves with them was there's a shortage of doctors in low-income countries. Detection and diagnosis of disease is low. About 2/3 of diseases in emerging markets are undiagnosed. People don't know they have diabetes or hypertension. And training programs, for training a health worker is often forgotten. You do a training session for a week and 6 months later, you don't remember what you learned. So what we did was effectively design for 10,000 health workers a training program linking to actual primary health delivery. So what we're doing is we're training people offline, face to face on diabetes. So we then give them our tech and our app and we train them on that. We give them a blood glucose monitor. And then for 2 months, they then go back to their community, collect data on the health issues. We identify the at-risk patients from that data, and then they go and do screenings on them. 2 months later, they come back, we check the data, we check the patients we found, we book the follow-ups, and then we train them in hypertension, say. And then they get offline training, online training, go back to their community, collect the risk factors, go through the data, do the screening for hypertension. Come back 2 months later, two months later, they come back and we train them again in a different topic. So yeah, we started off with 1,300 health workers. We're currently doing this for 3,000 health workers and looking to grow to 10,000 later in the year with a target of reaching 2 million people, which has been going really well and probably our largest single program at the moment. And then, yeah, just as a sort of different angle, I guess, and this is what I referenced earlier with insulin being, $20 or so, which is not affordable for poorer people. So we work with Biocon, which is one of India's leading biosimilars medicines companies. And we wanted to increase access to healthcare. We wanted to improve the affordability of diabetes treatments and really help some of the hurdles of accessing diabetes, such as that lack of screening, lack of awareness, personal barriers, fear of spiraling costs and not knowing how to administer insulin because it's injected, and thus, worrying for many people, especially when there's not that huge amount of health workers to actively support patients. So we partnered with Biocon, we shared the need, we shared the unaffordable pricing. We then went on to train the health workers with specialist endocrinologists coming from the government. We ran public health disease awareness campaigns, really making people aware of diabetes and the risks. We screened patients, we managed any referrals, and we really got those that did have diabetes to the help that they needed and the stronger government health system through the health worker education. And then, yeah, of course, we did find a large number of patients, and we then give them an insulin for about $3.50 delivered to their village. And yeah, it's been a great program. It's been really good to see. It's allowed us to expand into cold chain of products as well. We trained 20 health workers, about 20,000 engagements, and about 300 patients as well that were found to be in need of services. And we're currently just signing a second agreement, looking to scale up to 305,000 people, which is about 6 times the size of the current program. that's a great one as well. We're really proud of. And then just going forward, a slightly different one. So Philips, we did some research again within reach52 as us as an organisation, and we were looking at maternal child health, and we were looking at the real barriers to maternal child health services. And the World Health Organization recommends that a pregnant mother should get 3 scans to check their baby's safe and healthy. And we found that 85% of people in our communities had none at all, and 15% of them had 1. And here's the World Health Organization recommending 3. So, unexpected problems at childbirth, babies do, or childbirth and everything associated with it, of course, has a number of potential complications that can be spotted early. But if you're 5 hours from a hospital, the scans were $20 or $30 each. So again, just too far, too unaffordable. People in a resource limited setting simply can't afford it. So what we did, we conducted a willingness to pay study. We found out that about $9 was a price that women were willing to pay, or I should say pregnant mothers and their families perhaps were willing to pay. We worked with Philips to equip and train community midwives to do the ultrasound for $9 in the home, in the village. We partnered with local birthing clinics, government birthing clinics to again equip them. And then we ran the awareness campaigns, and those mothers that wanted to participate could get a point of care ultrasound in their village for $9. And again, if you went to the hospital, it's $20, and probably the cost of travel is $10 on top of that. So it's a significant cost saving. There's a small margin in that for us to sustain the service. And obviously, we're really looking to contribute towards improved maternal and child health outcomes through a proactive screening approach. And then, we thought we'd put this slide in because we are quite a sort of data-driven impact organization. This was just some of the research we did. So working out that just true price point, we can't do it for free. We are not an NGO. We are trying to build a social business. We took different concepts. We worked out the optimal price point that people could afford and they were willing to pay. And we sort of built a service beneath that to, make sure we could keep it sustainable, but also people had a price that they were happy and willing to pay based on being, a pregnant mother. And then, just as a sort of slightly different one again, another diabetes program. We've been working with Medtronic Labs, who are based out of America, looking at, again, social business models. This one was really running a more high-touch diabetes and hypertension service. So as we were screening people, we found that people really needed more high-touch support. So again, like with insulin or whatever I mentioned earlier, it's not just super easy to administer. People need higher touch support. So what we did with them was create an affordable monthly service for diabetes and hypertension, which included your medicines, your screening, nurse education time, access to Facebook chatbots and digital services for self-learning. And it was a fixed monthly fee. So all of your medicines and, blood glucose test strips and so on included. And we just wrapped up that project, really great to see that close to 90% of enrollees had their blood pressure under control, up from 60% at the start of the program. Knowledge of nutrition and complications is increasing. We noticed an 8% increase in the number of diabetics that were being managed better. And 76% of people were very satisfied, 22% satisfied. So great satisfaction scores, again, with people paying an affordable out-of-pocket cost for these services. And of course, we're improving the clinical outcomes as well by providing this better support. And that's it. Again, you can see my personal email, but again, would love to hear from you if you would be interested to know more. Edward@reach52.com. Really thank you for listening if you've got this far. And I hope there was something interesting and valuable to learn. So thank you. Hope one day we might meet in person and this could be a physical conference. And please do get in touch if you'd like to know more. Thank you.